And I don't think we'll find anyone more involved in the studies, more passionate about quad tendon ACL, which he'll speak to you guys about today. So thanks for coming, Dr. Mansfield.
Hey, thank you, you guys. I appreciate it. It's a privilege to be up here talking to you today, and I'm tasked with convincing everyone why they should be using quad. I know some of you are already using quad. I kind of highlighted it in a bit of gold to say, and maybe challenge a little bit to say, rather, why should I use quad? But I think I want to see if I can convince you why am I not using quad as my first go-to, because it may be, and I'm going to tell you, the data is taking us to a point where we have to start thinking, is this the new gold standard, in fact? And I do have to make a disclosure. I have a background in programming, and so I do a lot of building and work in AI. And so we do a lot of motion analysis stuff with the kids. So we may have to chat later, see what you think about this. But in any case, I'm going to get going. I'm going to try and convince you all why quad is something you should be thinking about. And on top of that, how do we incorporate this to make it a reliable and efficient prep in the OR to get through this and do it quickly and improving our results? Because we know ACL is challenging, especially in the young kids, the young female athlete. It's really been the focus of trying to figure out how do we do better with this. I'll go through some of the history. We'll talk about the harvest. We'll go through the graft and then talk about outcomes at the end. Just I presented the 6-year outcome data doing this technique. It's doing pretty well. So I think it's something we can think about. But of course, interest in quad, it's exponentially increasing. And it's not a new graft. Really, the late 70s into the early 90s is where we started using it. But the issue is that it was just not the type of graft we're using today. It was more of a substitution graft. We're taking retinaculum, parts of the patellar tendon. It was not having very good results. It really fell out of favor. It wasn't until the early 2000s that John Fulkerson and others started to revive this idea, and they started looking at this again. So you know what, this actually might be a pretty good graft. And on top of that, maybe a graft that has the least amount of problems. And just looking at it, it's a beefy tissue. And when you compare it side to side with the others, it does make you feel like you're putting something very solid into the knee itself. The anatomy is ideal for ACL. The thickness, the length, many different techniques, whether you want bone block, whether you want to do aperture fixation, it's really set up for a good graft. And so what I'll tell you is I think it's a bigger, better, stronger graft. A lot of advantages when we look at inside the knee. Of course, it's a lot thicker. Pound for pound compared to patellar tendon, much denser, 20% more collagen. When we do histologic samples of this, much similar to the native ACL, more than patellar tendon, and a higher load to failure. X at Emory has done a lot of work looking at quad, and so a lot of these studies are based out of his clinic. But really, this thing is almost twice as thick. It's stronger, it's stiffer, and so it looks great. Potentially some pain advantages. Interesting level 1 study. Quad, less pain than hamstring. What we're all worried about, though, is extensor strength. What about extensor strength postoperatively? Early looks at this in the cadaver lab and clinically are good. There's been a lot of good papers recently that show that this is an ideal graft, that we get the extensor back. I'll show one paper, AJSM, in just a moment, that puts that into a little bit of a question. But Volker Musal and those guys did a lot of look at this too. Good return of quad, no difference. I think the other thing is, are you doing full thickness or partial? No difference. I think you can do either one. Interesting study also this year, and this is something I've always been a little bit worried about, because especially in that young female, when you know that quad's not going to be that big, are we going to be causing a big problem taking out essentially a pretty high percentage of that quad when we do with them? And so this also, again, this is Volker Musal's group looking at this, 84 patients, decent graft size, 9.4, and they wanted to look at preoperative MRI size measurements and then isometric testing 5 to 8 months, no difference. And so they're worried, and their hypothesis was that this might be a problem taking these grafts in these people who have really small quads, but they found no difference. So I think that this really made me feel better that, yes, we can take these quads, not be as worried. I'll go over a couple issues with it. They had about 80% quad at that 8 months time frame. It does seem to do a little bit better in males and those who are a little bit taller. This is the one paper I wanted to bring up. AJSM, really nice paper. Over a year, they started looking at isokinetic strength testing. Not a lot of patients, 26 in this. They're doing 10 millimeter wide harvests. And they wanted to look at full thickness versus partial thickness. The full thickness, of course, these are a little bit bigger, a little bit more than 9.5. The partials were a little bit less than 9.5, but they did find a significant difference with the full thickness, and that there's a deficit in peak torque, average power, and total work. And so I think this is an interesting paper that does call into question how our extensor actually does with these different types of grafts. I do want to point out, though, in this paper that when they do their repair, and I have a different philosophy for how to do this, they were only repairing the deep capsular layer. They were leaving the top of it open, which is a bit surprising to me, because part of the philosophy, in my opinion, to get this right is to work on increasing that force transmission, especially with the rectus, through that extensor, because we know the rectus has a high proportion of those type 2 fibers that quick twitch. And if we're not restoring that force tension relationship, in particular, we learned a lot just from rotator cuff on that tension side. I think it's really important to try to reestablish some of that force transfer in the extensor. So I'll just say that a lot of people leave it open, but I'm going to talk to you about how to just close it and do a good job at regaining that extensor. And I think that this is not addressed in the paper, but personally, I think that we're going to have better outcomes by doing some of these better closures. And that's what we're going to do today. Outcomes, good outcomes since 2015, equivalency, but what is difference? Less anterior knee pain, especially kneeling pain. And so that's really what's pushed me into doing more quad. It's just that it's done very good, has a very convincing track record, in particular in the pediatric population, until we get to 2020 and the Danish study came out. Now, this study, in 2020, when this came out, I was really questioning what I was doing, because it's a great study. Martin Lind and their group put this out, almost 17,000 ACLs, higher revision rate, even after they took away the first third. So I think they're surprised to see, is there a learning curve issue? Still had a higher revision rate in their group. And so I was a bit worried during this time frame, and I was wondering if I was really just tricking myself. I think their group was worried about this too, because Martin Lind's a big quad proponent. And so they followed this up the next year, and they separated into the people who are doing it more versus those who aren't doing it as often. And that's where they found is that really those who are doing it routinely, what they call high activity clinics, those are doing fine, no difference. And so their suggestion is that, if we're going to do quad, we should be doing it. We should be able to keep up with it, because then you're going to have the best results with it. So that's when I felt pretty good about moving forward with this. In fact, our Kaiser group, Greg Miletus, had a great study last year. Now, I'll remind you, the Danish study was about 17,000, 1 to 2 year follow-up. The Kaiser registry is almost 20,000, 3-year follow-up, quad, no difference. What we did find, though, is that there's a higher revision rate with hamstring compared to BTB. So it is something to think about. We have a couple of follow-ups. Dr. Miletus reached out. I'm going to be part of a follow-up to this, because we're going to zero in on the gender differences and really the 22 and younger to see what that looks like, and also size. We have a couple studies pending. I can't talk to the data just yet, but those are going to be submitted and sent for publication. We can really put together a pretty compelling story that the data is taking us down. What about the pros? Still not a lot of data yet. The NFL population is a very challenging group. They tend to do the worst, whatever we do. NHL, they do the best. Hamstring still worldwide, the most popular graft. But again, this is in the Pittsburgh group. Now, the late and great Freddie Fu was actually on a couple of these in the end, because he was gaining more interest, especially in how the quad can restore that tibial insertion. So I think that there's a lot of advantages when we start to look more and more into quad. And I think we're going to see the trend moving that way as well with what we're seeing. So I'm going to switch over just to show a little bit how I do it. And it starts in the clinic. We learned a lot from X, and he had a great study. How do you measure this preoperatively? The field of view doesn't go high enough. Typically, we kind of get truncated whenever we get these. So we estimate. So essentially, I go 3 centimeters up, measure the thickness there, and that's a pretty good approximation for what we get once we get up to about that 6 or 7 centimeter length. And what I'm hoping to see is somewhere around a 7. Somewhere around a 7, I'm feeling very confident we're going to have no problems. And really, it's just a matter of preoperatively knowing, am I going to do a 9 millimeter width, which I do almost always, or am I going to do a 10 millimeter width? If I'm worried about size, if this starts getting to 6.5, or starting to flirt down at that 6 millimeter range, then I start thinking, I should probably just do a little bit of a wider on this if I can when I look at it. So this just helps think about my sizing in the beginning. Over 5 feet, no problems. I've only had 2 patients where I really had true length issues. In those situations, I did bone block to do that. But here, we look at the height. If you're over 5 feet, you're really not going to have much of a problem. Great study also a couple years ago in a pediatric population, which are ones that we always worry about. They were just going a centimeter up, and measuring. And they found the same thing. So if we get around that 7, that lucky 7, we're going to be pretty good. They found that 6.7 or above, kind of in that thick area, you're going to be pretty well set to get at least an 8 out of that. So those are the numbers I'm really looking at. Technique-wise, dealer's choice. Now, if you like to do transverse for your portals, I think it's fine. In fact, that's pretty popular. Vertical, same thing. My incisions are so small now that has not made a difference whether I go transverse or vertical. I've done both. And for a while, I was going transverse to make it a little more sexy and cosmetic. The challenge is that I'm pretty aggressive with motion. And so I did have a couple of wound issues post-operatively. Maybe that's just dealer. And I do a lot of sub-Q stuff, so I don't really put any sutures on top. So that might make a difference. But I had some healing issues, and it's kind of a nice way to do it. But I ended up just going right back to the vertical. I've not had issues with cosmesis because you get pretty small when you do this a little bit more often. And I like it too because if you're doing MPFL in the pediatric population, it's actually nice. I've done a handful of these cases. You just take the rectus, a little sheath of it, turn it over, gum on the wall type of repair. And these really young kids, it works great. Doing it today, I would say that we can do just a little incision to see what you think, whatever way you want to do it, just to get that view and look. And then we can just open it up. Because the approach, it's easy. There's not much here that you have to be worried about. There's a little bit of a fat pad that you take out. One thing I'll caution you about, because everyone says, oh, cut the fat, cut the fat. I take the fat deeper to get the visualization. A couple of females, I was pretty aggressive on trimming out that fat, and you can get this divot that they're not happy about. And then you have to look at this little fat pad deficit divot for the next year. So I would just say that the superficial fat, it's not a big deal because you're gonna be able to retract that. The deep stuff, that's kind of what we're trying to take. If there's a little peritoneum fascial layer, will open up, and then you're just right there. You're on a plane. I take a key elevator, just open up that spot with a Raytech or a sponge. You're gonna have a great view. In terms of the harvest, I do want to go back to anatomy because we have to be mindful of the split. And so there's something called chasing it deep. We just want to make sure we're chasing deep on that graft because if we're not careful, you're going to follow the path of least resistance. And all of a sudden you just skive up. And I was like, oh my God, you got this tiny little wisp approximately. So you do have to be chasing it deep when you're doing this. And there's different tools, low profile things you can use. And I do use those too. But the problem is, if you're not careful, if you're not being mindful of this split, you're going to end up with a problem at the end of that. When I first started doing this case, just a 10 blade and scissors, so you don't need much. I was doing a little more open, and it's a pretty easy thing. You just take it in. You can be mindful of your depth. I was just putting a little sticker on the back table at my 7 millimeter mark so that I can watch my depth and just, I don't think it matters if you're doing full thickness, but if I can avoid taking more, as much as I need is better. So you kind of just control your depth with just this. It's pretty easy to do. There's a lot of tools out there to do the low profile stuff, to do minimally invasive. I use these things too. And so there's a lot of things that we can incorporate to get that incision a little bit smaller. But today I think it's just be fine, just open it up and have a nice open view while we do this and harvest it. Retractors and visualization is a big thing. Now you can do it blind. And in most cases, you're going to be fine. I have a lot of partners that do it blind. It's not a big deal, but every once in a while, you're going to have a problem because if you do it blind, you put the scope in, you mark where you're going to go, but you got to watch the muscle. And so if you're not being mindful, it's pretty easy to get into the muscle, to have a problem. Like I said, in most cases, you're okay, but then you get that one that just ends up being a disaster. And so I do look. I like to have a little vis. Starting out, just Army Navy was fine. Now I'm using a lighted retractor. We actually have some here if you wanted to see what they look like. They're just these small little lighted retractors. For the longest time, I'll show you something on the back table that I used in the vast majority of my cases. You'll notice that there's this little retractor back here. This is a powerful tool. Half of a speculum, it is amazing. I would really encourage you to have this in your toolbox because we use this for open meniscus transplants. The quad is great. In fact, I use it a pretty small, like a thin, long one works really, really well. Now, the new lighted retractor I'm using, it's a pretty small, low profile thing. So when I make these incisions, it really just has to be big enough that I can fit something there just to take a look and then get the blade in there. It has a really good view doing this. So we can kind of show you a little bit what that looks like on the back there too. Air medial tends to be a little bit better, but we want to leave a strip. So I just go right off the VMO. That's going to keep you pretty safe. Right off the VMO, leave a little bit of tendon there. And then it's medial to lateral type of a trajectory to get that good fiber. Every case, I just take a key elevator, mark it at 7, because I just want to make sure length looks good. Like I said, I've only had 2 cases that was really concerning, but if you check your length prior, and it's just easy enough to do it on a key elevator, just make sure that a path looks good. Most of them are around 10 millimeters wide anyways on the head, so you can get a really good sense of what you're going to be able to get, and then also a little bit of a path. I do a little marking pen on it just to give myself some guardrails. I'm not as good as everybody. I worry a lot, so I still do a little bit of this on my graft. If you're doing bone block, I just wanted to point out you got to be a little mindful at this top of the patella because the slope is different. I think we're all used to doing the inferior patella work. The top is actually great. There's a slope to help you dissect the quad off of it. But if you're taking bone, just be mindful that you don't have to take as much because it's going to be longer on the inferior aspect of it. Now, in the hamstring, we're always worried about too small. The quad is the opposite. Going too big is the worry. And in fact, when we start looking at sizing, that's the other thing that we're looking at is a lot of us are going smaller and smaller and smaller. Because I don't think the hamstring data really applies to quad. And so we can go smaller. And what I'll tell you, he actually looked at his 700 cases just to see, is there some kind of correlation between size and problems with cyclops, arthrofibrosis. In his case series, about a 7% return with this problem. And they did find that the females certainly have a higher problem. And once you start going above 9.25, in that 9-ish higher range is when they started to see some issues. Concomitant meniscal repair, of course, but so typically I'm trying to go for around an 8 to 9. Now you can customize this because, I've done this on the big guys too, the linemen. You got to go bigger, so a 10 and a half in them, no problem. They're going to have a lot of space. Females typically, of course, maybe a little bit of a smaller notch. You got to be a little bit more mindful of what size. And so I'm really kind of going more in that 8 and a half if I can. But you can be pretty good with your graft sizing once you pull these out. The view with the lighter retractor, VMO is on the left. So you're just going to have a nice open strip. You can see this pretty well. Take your graft. So essentially we're going to do however you want to do, either a 10 wide or a 9 wide. Almost always I just do a 9 width, and that does really well. So strip that out. We're going to cut it up, truncate it. And then this is the important part that I think that I would encourage thinking about rather than just leave it open or just do minimal. Half of my cases, actually, I kind of left it open. And then I would do a little bit of a repair at the patellar side. The worry being Alta. I was always a little bit worried, if I close this, are we going to have an Alta problem? I have not seen this. I've been doing this for a long time now. I've not had a problem. And so what I would recommend is, number one, putting a bit of a bolster stitch at that stump to the VMO. Very rare complication. It's just the pop eye of the knee. I've had one partner have one of those. It's more of an issue if you're getting pretty high up and you're getting close to that muscle. What can happen is that rectus layer can pop and retract. I have not had that happen. Again, just being mindful of your length. And I do this bolster stitch, which is like a modified figure of 8 from that stump into the VMO, just to give it a little bit of an extra support. I've not had a problem. And then I close it because I think that trying to restore that force transmission through the extensor is pretty important to get this back. And so I've been closing this now, just some side to sides with our shoulder suture passer. These patients have been doing much better since then. What we're hoping for is a nice beefy graft once we pull this out. I think the bulk of what we're talking about is how do we now add this in. This is where I've really changed my practice a lot in terms of how do we add this. Do we add it on top of the graft, inside of it, at the end of it, hybrid fixation? Actually, a nice paper, biomechanical study out of Japan, 2022, wanted to look at this because a lot of people add this to the end, and a lot of devices have you add this to the end of the graft and either tie the knot at the end or go down, then back up and tie it up inside the graft. So they did this. They looked at, well, what if we tie it at the end, up into the graft? What about adding it to the graft itself and then just baseball stitching it? Adding it up into the graft itself tended to be the best, highest load to failure, least elongation. And so what I'm going to talk to you about here today is how to do a variation of these two these two types of morphologies. And this is what I've been doing really for the last 6 years-ish, this type of procedure. Now, our group over in Mammoth put out a nice paper in 2015. Why not just open up and split it, put a closed loop in there and stitch around that? And I did do this for a long time. The challenge here is that by doing this, there is some risk that you capture your suspensory. happen in 2 cases. It's devastating when you go to try to reduce and it's not doing it. And then you realize that somehow you captured it. There's a problem. Oh my God. Okay. So this is a problem. After that happened, I really switched it up to be a little bit of a safer way to do it, which is easy. It just requires 2 angiocaths, and that's going to act as our shuttling device. So that way it keeps us all pretty safe. We're not worried about capturing things. We're going to have a nice little area where we're going to put our open loop through. No worries, works great. And it's really geared so that our associates in the room can do this. And that's how I do it now, is essentially we trade places. I do the harvest, I put it on the back, I do a little bit while the wound's being closed, while the incision's being closed. And then we just switch spots. Once that's happened, I scope in and the graft being prepped. But I know that with this angiocath, I know where that spot's going to be, and the technique is made so that we don't have to be putting a lot of work into this. We can be doing other things while that graft prep is being worked on. And so I do make the markets a little bit like hamstring, 20, and this one's actually at 15. So I put the graft, the suspensory higher into the graft actually. So it's pretty high up. And we do a double locking stitch. Now this double locking, a lot of my colleagues say, God, that seems too complicated. It's not. It's very similar to what you do already. And I'll show you what it is. And then we keep those tails, that whip stitch that goes around, we keep them because that's what's going to be helping us pull it into the tunnels. If you cut those tails, because the suspensory is so high up in the graft, it's going to be hard to get that nose in. So these tails actually help to guide it in, but it also acts as another fixation point. So essentially, where that tension is going to be a little bit closer to the knee itself. It's going to be a little bit more similar to aperture fixation, the way I do this. And then we have those tails that go up into the button as well. And so when we do these grafts, we'll just measure mark 20 and 15, put your angiocath. I'll show you the technique. It's a double locking technique. It's actually pretty simple. It just double loops it in with 2 locks on each side of it, finish it out and do a little bulletizing, and then we run this through the button. So when you're on the back table, you don't need much. You really just need those 16 gauge angiocaths, some Alice clamps. When I first started doing this, I did a lot of tape onlay. So there's this rip stop that you can utilize, and you can make your own. There's some commercially available ones. The way this technique works is I don't think you really need it. It's very robust. So I've stopped using that tape because it is a little bit annoying trying to spear it every time you're passing it, and this speeds it up. And so what we're going to do is essentially you get just about 2 passes because it's pretty high up there where the angiocath is. So you'll start at 20, probably just get 2 passes. This one nice and tight next to the angiocath because you're going to want to leave a little bit of space between those 2. You're going to come back around for a locking stitch. So leave a little bit of space between those first 2 passes. And it's a really thick graft. So when you play with it, you're going to feel that you got to put your fingers behind it to really tension it up and get it. And then 90-90 tightening every time you go through. So what I'm doing now is I'm going across the angiocath. I'm on the other side now. And now I'm pushing through. But again, you want to leave a little space in between this pass and the angiocath because we're going to come back around for our double loop to get this in. So essentially just a normal whip. We've done 2 on one side, 1 on the other, leaving some space. So we're going to come back around, tighten this up. And here I'm stabbing that tape every single time. But again, I've stopped really using it. Now what I'm doing is I'm going to come back around to the other side of the angiocath. And just like you normally would in any blocking technique, just go right behind that loop that you put before. Make that locking stitch, pretty easy. But that's why it's good to leave a little bit of space because you come back around on this side, put it through, tighten it up. And then once I tighten up, we have our first lock on this side. I'm going to go across to the other side now, and then that'll be our second lock. And so here, same thing, come back around. I'm going to put this right behind that other one. And so what we're going to be left with is essentially 2 locked stitches on either side of our shuttling angiocath. And once this is placed, you can feel very confident that you're going to have a length, stable position in your graft. You know, I'm not so worried about how tight are the knots and all these other things we have to worry about with hamstring. How much do we pull into all these different aspects of doing a really good hamstring graft? It's really just making sure that we have these 2 lock stitches double looped inside, and then we're pretty much done with the technique. Now you can check your angiocath, just make sure you haven't captured it, give it a little wiggle. And the rest of this is just moving your way down and finishing out the prep. And so here what I'm going to do is just put a few more. The fibers of the quad, they run all relatively parallel. And so as you get closer to the angiocath, it's going to want to pull out on you. And so I am pretty much stress testing when I get close. You don't have to go to the very end because this is going to pull out. So I go near the Alice clamp tip, but I am pretty forceful on these last couple because if it's going to pull out, I want it to pull out now, and I can certainly just incorporate that. It's not a big deal. But yeah, a lot of stress testing once I get down, and then just like finishing off any whip stitch construct, I do one last lock right at the end there. You're going to have a little bit of dog ear and a little extra material at the end. Now, we can trim a little bit prior just to prevent that, but this is a good opportunity that you can actually capture some of those dog ears and do a little bulletization. So I'll just take a Keith needle, come right across there, grab some of those dog ears, and then tie that up. And then that's going to help prevent some of this dog ear phenomenon and save you a little bit of time with this bulletization portion. But then I'll just tie it, do about 5, and then we'll bury the knot in. It's good. I don't like seeing that knot stack hanging off the end of it. It's not a big deal, but I do like to just bury and put it right through there again. It's thick, so you're going to want to have that needle driver with you to get through this tissue. But once you put this through, I mean, that's it. So you're going to have a very good, solid position for your suspensory. And you do the same thing on the other side. Just flip it around. Have a great and again, I encourage you just to kind of feel what it feels like. Just give it a good yard when you're back there working on this stuff. And then I put those tails into the button too, because that's going to help you out. And so in the end, you're done. I gave it a name because it's too annoying to dictate this whole thing. So I call it the quad lock. Seems very, very fun. But that way the dictation is a little bit easier now. So I just say the quad lock technique. It's intra-graft fixation technically. One note I will say, because you can do whatever you want, whether you flex ream, whether you like to hyper flex. If you're doing the retrograde, the sets that Stryker has are a little bit different. And I trained on Arthrex. And so some of those numbers are based off a great study in 2013, looking at how do we recreate that ACL footprint the best. That tended to be at the 110 degree on their guide. So on this, to recreate that's actually 55 degrees. So 55 degrees on that Stryker handle. Hand up about 60 degrees and the transepicondylar axis about 20 degrees. And that shows to really recreate that footprint the best. When you're looking inside the knee, good rule of thumb, a lot of these have marks on them. I like to see at least 20 to the front of the condyle. If I'm at least 20, pretty good length. Then I can get back there pretty well. I know I'm in a good spot and then really try and hit that ideal IDEAL position on the footprint. I do look at the button every single time. I don't do any fluoro, but I do look down. Because if you're doing it this way, it's pretty easy. Just put the camera down just to make sure you look good. I had a case where I was really, I thought, because I know you guys, you're going to feel that button. Feels good. In most cases, that's fine. There was one where it was strangely wedged inside the tunnel. It wasn't actually flipped. It was wedged, and it felt great. And when I put the camera in, I said, oh, my God, like this thing is actually just somehow wedged itself right into below the cortex. So I do look just to check, and then you can kind of fiddle around with making sure that it looks okay seated. Inside the knee, you're going to get this beautiful looking thing. It's not as shiny as the other grafts. It's a little rough around the edges. It's kind of a street fighter in a way, but you can clean it up, make it look good. I do change the morphology. It tends to naturally want to sit this way because it's not really a bundle. You're putting in more of a rectangle. And I actually sit it so that that rectangle, the superficial deep part of that graft is medial lateral. And then the edges are up and down. And what this does is it actually gives you more of a ribbon. And in fact, we have had a lot of data challenging the idea that the ACL actually is a double bundle. KSSTA and others have brought forth a lot of really good, robust cadaveric studies that are showing that ACL is really more of a ribbon. And it has a differential bundle appearance because there's differential torsion that goes through these tissues. And so I would just posit that it may actually be a benefit to do it in this format. And that's maybe why patella also does well, because patella is similar to this kind of morphology. And so recreates it well. I presented this outcome data. So I went 2017 to 2021 looking at how these were doing. Minimum 2-year follow-up, had 95 primaries involved in this one. Young, pretty active, high-risk sports in this cohort. A lot of meniscus in this cohort as well. Graft failure, 1.05%. The average graft size is a little bit on the bigger side. This is earlier on. I've been really trunking much smaller grafts recently, but females about a 9, males a little bit above 9.5. But despite this, really only one manipulation. Did have one infection, 2 returns for repeat meniscus, and then our revised ACL. He was a collegiate soccer player, failed at 8 months on the field. Return to sport on average is about a year. The extensor, I think, does take longer to come back. And in fact, if you look at the range, one of these patients to get their extensor back, 15 weeks. So when you're sitting there in clinic at 3 months and they don't have their extensor, you got to hold on tight. I was really worried about this one. But it does come back. and she's actually on scholarship now at a college program playing soccer. And so it's a little bit concerning the game we see that does take longer, but you do this technique, have faith, it's going to come back. In fact, I'm very aggressive at quad in rehab. A lot of stem, I go at it pretty heavy. It's because we are doing a lot of fixing on it, so I feel confident. Just go after that quad right away. No significance in terms of men versus women in return. There was a trend that women took a little bit longer, 6 weeks versus 7 weeks. Anterior knee pain did great. I did have about a fifth of them with transient pain, but chronic pain, pretty low. Graft size did not correlate with anterior knee pain. Gender did approach favoring females. But again, I would just say that I think that this technique is viable. It doesn't take much on the back table. And since I've been doing it, I just feel much more confident that that suspensory and this whole connection is not slowly pulling away in that early recovery. And so I would just say it's something I think worthwhile to think about and practice when we go back there. Some of the cheat sheets for this one, again, just starts in the pre-op, looking to see how thick is your quad on MRI, looking for a goal of about 8 to 9, trying to get 65 to 70 length. When you're looking up there, I'm still looking. I don't do it blind, but there's a lot of good retractors we can try. Chase it deep, repair the defect. The graft prep we'll go work on a little bit, but we do that 15 and 20, angiocath, and double whip it in. So I appreciate you guys. Thank you.